Good morning. Today we will be continuing with the second part of lecture of resective osseous surgery. As I had told you previously, osseous resection technique comprises of 4 steps: vertical grooving, radicular blending, which are osteoplasty procedure, then flattening of interproximal bone and gradualizing marginal bone, which are ostectomy procedure. Now we will come to vertical grooving. It is the first step because it can define the general thickness and subsequent form of alveolar housing. It is usually done by rotary instruments as carbide or diamond burrs. It is designed to reduce thickness of alveolar housing, provide relative prominence to radicular aspect of the teeth, provide continuity from the interproximal surface onto the radicular surface. Indications: thick bony margins, shallow crater formations, areas which require maximal osteoplasty and minimal ostectomy. Contraindication: areas with close root proximity or thin alveolar housing. Here you can see thick margin and blunted interdental septa, interproximal crater with heavy ledges of bone. Vertical grooving has been done to establish width and thin bone interdentally. Then second step is radicular blending. It is an attempt to gradualize the bone over the entire radicular surface to provide the best results from vertical grooving. It provides smooth blended surface for good flap adaptation. Indication: thick ledges of bone on the radicular surface, and contraindications include minor vertical grooving or thin fenestrated radicular bone. Both vertical grooving and radicular blending may be used for treatment of shallow crater formation, thick osseous ledges of bone in radicular surface, class 1 and early class 2 furcation involvement. Here we can see radicular blending, which has been done to reduce thick bony margins and establish physiologic bone form. Then flattening of interproximal bone. This procedure involves removal of very small amount of supporting bone. Indications include when interproximal bone varies horizontally, one-walled interproximal defect or hemiseptal defect, coronally placed one-walled edge of predominantly three-walled defect. Contraindication include class crater formation or flat interproximal defect. Advantage: helpful in obtaining good flap closure and improved healing of three-wall defects. Limitation: in treatment of advanced lesion, large hemiseptal defect would require removal of inordinate amount of bone to obtain flattened architecture. Hence, compromised osseous architecture is only logical solution. Here we can see flattening of interproximal bone, then gradualizing marginal bone, which is also a ostectomy procedure. Minimal bone removal to provide a sound, regular base for gingival tissue to follow. Failure to remove the window peak, allowing the tissue to rise to a higher level than the base of the bone loss in the interdental area. This step of the procedure also requires gradualization and blending of radicular surface. Hand instruments as chisel and curette are favorable over rotary instruments. Here we can see scribing of outline to be removed, minor ostectomy to establish physiologic contour. Here you can see in the picture outline of scribed bone and scribing complete. This is the final outcome of resective osseous surgery. Here we can see buccal and lingual view showing small interdental crater and buccal and lingual view of horizontal grooving. Bone is scribed prior to removal. Lingual view. Essentials of wound healing. After resective osseous surgery, thickness and thinness of bone that surrounds the tooth prior to surgical modification could be the single most important determinant for a successful outcome to a case treated with osseous resective procedure. Thick bone may be characterized as trabecular bone containing marrow interposed between outer cortical plate of alveolar process and alveolar bone proper of tooth. Has a greater capacity for regeneration because marrow is excellent source of regenerative cells and vascular support. Amount of bone exposure. Amount of bone that is left exposed following flap placement and suturing is another critical factor in repair or regeneration. Less than 2 millimeter of crestal bone exposure may not result in a significant loss of attachment, provided that bone is initially protected with a clot. Periodontal ligament is the primary source of granulation tissue during healing, with a regenerative capacity extending 2 millimeter beyond alveolar crest. If large areas of bone exposure occurs, only one half of bone resorbed in radicular area may be expected to regenerate. Palatal and lingual approach to resective osseous surgery. Surgical management of maxillary anterior bicuspid region has met with much greater degree of success than molar region. Careful study and consideration of anatomic factors associated with posterior maxilla and mandible explains more fully lesser degree of successful therapy, especially when pre-surgical morphology of molar teeth and surrounding bone is taken into account. Main aim is to create acceptable and maintainable periodontal architectural form by using anatomic relationships unique to topography of the regions. Advantage: prevention of some intrinsic problem primarily encountered with buccal approach, such as exposure of buccal furcation, presence of shallow vestibular depth with narrow width of attached gingiva over facial radicular surface of teeth, resorption of thin compact bone over radicular surface of teeth. Resective osseous surgery from palatal and lingual approach does not prevent necessity for surgical intervention on buccal aspect because almost all cases require buccal recontouring. But the bulk of crater reduction is done palatally or lingually to preserve the height and integrity of buccal bone, particularly when root trunk is short. Palatal approach, Oxenbein and Bohannan describe the palatal approach to osseous surgery to refine and complement the treatment of interdental crater in maxillary molar region. Indication: avoidance of buccal furcation which are located further occlusally than in mesiopalatal and distopalatal furcations. Buccal root proximity in molar area. Wider embrasures palatally, therefore wider spaces. Poor posterior access for proper instrumentation from buccal approach. Thin buccal radicular bone dehiscence and fenestration from central incisor through first molar. Greater palatal bone thickness around the arch from second premolar to second premolar, but thinner over palatal aspect of molars. Shallow buccal vestibular depth or a narrow width of gingiva or both. Palatal tissue is well keratinized. Lingual approach: Tibbets and colleagues in 1976 reported importance of performing resective osseous surgery in posterior mandible primarily from lingual approach. Indications include prominent external oblique ridge on buccal aspect extending obliquely from beneath mental foramen to anterior body of ramus, often resulting in shallow buccal vestibule. Enamel or lingual surface of mandibular molars and second premolar extends further apically than on buccal surfaces. Because of lingual axial inclination of crowns of posterior teeth, base of interdental crater is positioned lingually. If lingual bony plate is thicker, thin buccal radicular bone over premolar and mesial root of first molar. Avoidance of buccal furcation which is located further occlusally than lingual furcation. Here we can see correction of periodontal osseous defect using palatal approach. Buccal preoperative view from maxillary lateral incisor distally. Palatal preoperative view from maxillary lateral incisor through second molar. Buccal view after flap reflection and debridement showing class 2 furcation involvement and interdental crater distal to premolar. Palatal view after flap reflection and debridement showing class 2 furcation involvement and interdental cratering form premolars distally. Buccal post-osseous resective surgery. Majority of ostectomy is performed in molar region. Slight reduction at distobuccal line angle is performed. Palatal post-osseous view showing result of ramping the defect palate toward palate. Buccal suturing with continuous sling suture. Palatal suturing with vertical sling mattress suture. Here we can see 5-year post-operative view, buccal view and palatal view. Osseous surgery for complex osseous lesion, buccal view of irregular marginal osseous contour, occlusal view, we can see C which denotes crater, H for hemiseptum, IV for intrabony defect. Horizontal grooving, interdental osseous crater is in level. In D we can see scribing is used to outline the bone to be removed for ostectomy. E. Ostectomy completed buccally. Small spicules or window peaks still remain interproximally. Osseous contouring completed with interproximal smoothing of bone and no furcation involvement. Lingual view with irregular osseous margins. Occlusal view, crater, hemiseptum, intrabony defect. Horizontal grooving, negative bony architecture and mesiodistal crater formation. J, we can see vertical grooving. In K, we are seeing radicular blending is completed. In L, scribing of final contour completed. M, ostectomy completed with remaining window peaks. And N, post-treatment architecture with smooth flowing contour and no involvement of furcation. Flap placement and closure. Following the completion of surgery, flaps are repositioned and sutured. Flap placement either originally positioned or apically positioned. Originally positioned, advantage includes minimum post-op complication, optimal post-surgical pocket depth. Disadvantages include deep pockets initially, which diminishes over time due to selective recession. Apically positioned, advantages include increased width of attached gingiva. Disadvantages are more post-surgical resorption of bone, patient discomfort. Suturing can be accomplished using a variety of different suture material and suturing knot. Suture should be placed with minimum tension to co-adapt the flaps, prevent their separation and maintain the position of the flaps. Suture placed with excessive tension rapidly pull through tissues. Area is covered with periodontal dressing. Post-op maintenance. Periodontal dressing is removed and surgical site is gently cleaned of debris with cotton pallet dampened with saline. Resorbable sutures maintain wound approximation for varying periods of 1 to 3 weeks, depending on material which they are made. Sutures may be removed at varying periods. Non-resorbable sutures such as silk are usually removed after 1 week of healing. Some newer synthetic materials may be left for a period of 3 weeks or longer. After suture removal, surgical site is examined carefully and any excessive granulation tissue is removed with sharp curette. Patients should be advised to rinse with 0.12% chlorhexidine gluconate immediately after surgical procedure and twice daily thereafter until normal plaque control techniques can be resumed. Complications, persistent bleeding after surgery, how it should be managed, pack should be removed, bleeding point should be located, bleeding should be stopped by application of pressure, electrosurgery or electrocautery, repacking the area after bleeding cessation, sensitivity to percussion caused by expansion of inflammation into periodontal ligament, removal of pack, examination of gingiva for localized area of irritation and infection, cleaning or incising the area to provide drainage, removal of any remnant of calculus, correction of occlusion if needed. swelling, localized inflammatory reaction due to operative procedure, soft painless swelling of cheek in area of operation, lymph node enlargement, elevated temperature. In case the swelling persists and become painful, then antibiotics should be prescribed. Feeling of weakness, this could be systemic reaction due to transient bacteremia induced by operative procedure, prevented by pre-medication with amox 500 mg TDS beginning 24 hours before the next operation and continuing for a 5-day post-op period. Second post-op visit is often performed at the second or third week and surgical site debrided for optimal results. Professional prophylaxis for plaque removal should be done every 2 weeks until healing is complete. Healing after resective osseous surgery. As soon as a resective osseous surgery is completed and flap are placed, then there is initiation of inflammatory response, which is due to loss of nutrient supply to bone, necrosis of alveolar crest, osteoclastic resorption of bone, repair and remodeling. Osteoblastic activity has been observed even after 1 year post-operatively in humans, as initial loss in bone height is somewhat compensated to some extent by repair and remodeling. Pocket probing depth following flap surgery with and without osseous surgery. Following osteoplasty, ostectomy, and apical repositioning of flap, pocket depth is significantly stable over the long term. In similar flap surgery, but without osseous surgery, soft tissue flaps must be readapted over the remaining cleaned osseous defect. Deep residual pockets remain and they have poorer long-term prognosis. Recent advances in resective osseous surgery include fiber retention, resective osseous surgery. Then we will come to piezoelectric surgery. What is piezoelectric surgery? Use of ultrasonic vibration for cutting of bone was first introduced 2 decades ago. Piezoelectric bone surgery, known simply as piezo surgery, is a new technique of osteotomy and osteoplasty, which require use of micro vibrations of ultrasonic frequency scalpels. Piezo surgery device is essentially an ultrasound machine with modulated frequency and a controlled tip vibration range. Ultrasonic frequency is modulated from 10, 30, and 60 cycles per second to 29 kilohertz. Principle of piezo surgery is ultrasonic transduction obtained by piezoelectric ceramic contraction and expansion. The vibration thus obtained are amplified and transferred onto insert of a drill, which when rapidly applied with slight pressure upon bony tissue in the presence of irrigation with physiologic solution result in cavitation phenomenon with mechanical cutting effect exclusively on mineralized tissue. Here we can see piezoelectric effects caused by crystal material like quartz to generate an electric charge when the crystal material is compressed, twisted or pulled. Reverse also is true as crystal material compresses or expands when the electric voltage is applied. History: ultrasonic osteotomies were described by Horton et al. Prior to 1968. Tommaso Versillotti in 1918 invented piezosurgery instrument which uses modulated ultrasonic frequency that permits highly precise and safe cutting of hard tissue. Versillotti in 2000 renewed this approach for nerve and soft tissue protection surgery. Disadvantages and limitation. These instruments can often be used when bone is very dense. They generate significant amount of heat in cutting zone and must be minimized by water irrigation. Overheating of adjacent tissue may alter or delay the healing response. Manual instruments, although offer good control when used to remove small amount of bone in areas with relatively less dense mineralization, are difficult to control in cortical bone, particularly when precise osteotomies are essential. Other factors are motorized cutting tools also decrease tactile sensitivity, Reduced rotational speed decreases not only frictional heat but also cutting efficiency. Slower rotational speed necessitates increased manual pressure, which increases the micro vibration of cutting tool and further diminishes sensitivity. Need for piezoelectric surgery requires much land head pressure, enhanced operator sensitivity and control, safe and precise cutting, sparing of vital neurovascular bundle or general soft tissue. Cutting action is less invasive, selective and thermally harmless nature, resulting in low bleeding, less collateral tissue damage, resulting in better healing. Cavitation effect on physiological solutions are virtually bloodless surgical site. Other factors could be post-op excellent wound healing, piezoelectric instrument, visibility of multiple working area are much cleaner. Innovation of this technique is mainly due to three factors: micrometric cut of 60 to 200 micrometer, selective cutting, which works on hard tissue but not on soft tissue, relative blood-free surgical field due to air-water cavitation, effect of ultrasonic device. Complications include soft tissue structure may be perforated or injured by application of excessive mechanical force from instrument tip. Pronounced temperature increase is noted in area of handpiece after prolonged application. Possible side effects such as thrombogenesis and impaired bony blood circulation need to be examined. These are histology results. Comparative surgery have demonstrated both clinical and histological advantages of piezosurgery. Here, in first diagram, we can see bone burr, second bone saw, and third is piezosurgery. Indications: oral surgery, root extraction, apicectomy, orthodontic surgeries, palatal impacted teeth removal, orthodontic corticotomy, periodontal surgery, root planing, root debridement, bone harvesting for regenerative surgery, implantology, bony window osteotomy in sinus lift, bridge expansion, osteoplasty, implant site preparation, extraction for immediate implant positioning, technology, ultrasounds of piezoelectric unit have been developed specifically for cutting bone tissue and doing minimal damage to soft tissue. High frequency oscillation between 24,000 and 29,500 Hz modulated with low frequency between 10 and 60 Hz enable efficient and controlled use and improved the healing of tissues. Control: piezosurgery unit is controlled solely by means of an interactive keyboard. Each command is shown on an easy to read display. Two basic program, bone and root. In bone program, it is possible to adapt power to any of four levels depending upon bone quality. In root program, power can be set to either perio or endo. It has an automatic feedback system for constant control of power of ultrasounds, which can be adjusted in case of need. Piezosurgery unit includes surgical tray, torque wrench, liquid, peristaltic pump, handpiece. This is a diagram of piezoelectric unit. These are instruments, instrument tray, torque wrench, handpiece, water supply, peristaltic pump. Insert tips could be sharp, which enables gentle and effective treatment, then smoothing, have diamond surfaces enabling precise and controlled work on bone structure, or blunt, used for preparing the soft tissue, for example, elevating the Schneider membrane for lateralizing nerves in periodontology. Here is the diagram of sharp instruments, smoothing instruments, and blunt instruments. Basic kit and sinus lift kit. Procedure: elevation of full thickness flap beyond mucogingival line, removal of marginal collar of tissue including pocket epithelium, granulation tissue with curettes, thorough scaling and root planing of exposed root surface. Handpiece is guided firmly over the bone but without excessive pressure. Buccal and lingual flap is repositioned to the level of newly recontoured alveolar bone crest and secured in this position. Here we can see the procedure. Thank you.